Today we're going to talk about drug use and abuse. Our goals for today, we're going to discuss drug use and abuse for patients. We'll look and define some various concepts such as tolerance, dependence, and withdrawal. And then we'll look at drug use and abuse for healthcare providers. Drug use, as you're probably well aware, is a very common problem in the United States. And we're talking not only about drug use and overuse, which would involve prescriptions and over-the-counter drugs, which are commonly overused. We're also talking about drug abuse of these medications as well, involving both legal and illegal drugs. One of the common ways that these drugs are abused is to combine them, combined substances. So we're talking about polydrug abuse, which would be the combination of multiple drugs at once. So we're talking about alcohol and tobacco and over-the-counter drugs, for example, or Percocet and Ritalin, a variety of different combinations. And drug use really is a problem that can affect all different types of patients. And it's really easy for us as a clinician to get fooled when we've got patients that come in, that are very well dressed and put together, and they've got a nice story for us. And then you start talking to them, and it's just like red flag after red flag after red flag starts going off in your mind as you listen to their story that it takes a while until it dawns on you that, oh my God, this guy's shopping for pain meds. It's really easy to identify sometimes or jump to the conclusions when you got people that come in that maybe aren't as well dressed or put together, that maybe they're shopping for drugs. And so you have to remember that this is really a problem that's not restricted to age, sex, race, or socioeconomic class. Really, it can be anybody. And I've seen it from, pediatric patients where it's not them, but it's their parents that are shopping for the medications. They're just using their kid to do it, all the way to an elderly, older lady who was hooked on Percocet. So it's a variety of patients that can be affected. Let's talk about tolerance for a little bit. Tolerance is defined as the need for progressively higher doses of the same medication to achieve a desired clinical effect. This is very similar to the concept of tachyphylaxis, where we have repeated dosages that have a less effect each and every time. One of the things that's interesting about tolerance, essentially, and one of the ways to best describe this is the use of opioid analgesics, where the patient essentially becomes tolerant to the effects of the opioid agonist, and in order to get that same analgesic effect, we have to give increasingly higher dosages of the same opioid agonist. But what's interesting is that all the clinical effects are not the same. So, for example, while you may need a higher dose of opioid to produce the desired analgesia, the GI effects that we see, such as constipation, it's there whether you got a low dose or a higher dose. The GI effects are continuous, and it's not like that. That is not subject to the effects of tolerance. In terms of the main mechanisms of how tolerance is developed, there's two main mechanisms. We see either an increase in drug metabolism, or we can see receptor downregulation. So with increased drug metabolism, essentially what we have is an induction in the hepatic enzymes responsible for metabolizing those drugs. So those would be a lot of your CYP450 drugs, where essentially we're revving up the liver so it can metabolize these drugs at a much faster rate. And so that's going to lead to a decrease in the availability of the free drug, which is able to bind to the receptor sites. And it's also going to lead to basically less drug overall. The other concept that we have or mechanism is the downregulation of the receptors, where essentially we're continually bathing those receptors in the drug that's available. And then over time, the body's going to compensate by decreasing the number of the available receptors. And so that's going to lead overall to a decrease in the long-term sensitivity, or a decrease in the effects that we see. So the signs and symptoms that we see with tolerance, we see a couple different things. We're going to see a reduction in the duration of action. So we're going to see a decrease, for example, let's take benzodiazepines. We're going to see a decrease in the length of sedation or the duration of sedation. We can also see a decrease in the length of analgesia if we're talking about opioids, for example. We may also see a reduction in the peak effect. Specifically, we see this with our analgesic effects with opioids, as I just mentioned. And so if you look at the lower right graph, you can see that the first time the person uses the drug, they're going to have a very typical peak effect, and then it'll kind of taper off. But if you compare that to the 100th time, which is the blue line, you can see that the peak effect nearly is not large enough, and then in fact we actually see kind of a withdrawal towards the end. So tolerance, in terms of the rate at which it develops, really depends on the specific drug that's used. It involves, or it depends on the frequency that the drug is given, the dose, the amount, the length of exposure. And oftentimes we really don't see tolerance start to develop, especially with our opioid agonist. We don't tend to see it until, several days out. So about, well over a week or so. That's where we start to maybe see the beginning signs of tolerance. It also depends on the patient. There's patient-specific factors. But the key point to take home here is that if we use bigger dosages, more frequent dosages, and longer courses of drug therapy, we're going to have an increased risk of the patient developing tolerance. So tolerance can also occur with both legal and illegal drugs. So some examples that we see here would be your prescription opioids like Vicodin or oxycodone. We can see it with illicit opioids like heroin, cocaine, alcohol. All of these drugs are subject to the patient developing tolerance to their effects. Now let's talk a little bit about dependence. Dependence is really a condition where if we start to withdraw, the patient will develop withdrawal symptoms if the abused drug is withheld and not administered. And so those withdrawal symptoms can involve both physical and psychological, or a combination of physical and psychological effects. This can also involve the chronic use of legal and or illegal drugs. So once again, this can involve both. It's not subject to just illicit drugs. So some examples there would be alcohol, prescription opioids, illicit drugs like heroin, etc. So looking at the symptoms that we can have, from a physical standpoint, the physical symptoms really involve changes within the biology of the actual patient. So we can see changes at a cellular level, at a systemic level, and at a synaptic level. Oftentimes, because we're talking about actual physical changes in the body, we can manage these patients' physical signs fairly well by administering other medications. When we talk about the psychological aspects, though, the rate of development, similar to development of tolerance, really depends on a lot of different factors. Once again, it depends on the specific drug used. It depends on the frequency, the dosing, the length of exposure, a lot of patient-specific factors. But once again, the same kind of underlying key point is that we're going to have an increased risk of developing dependence if we use bigger dosages, more frequent dosing, and longer courses of drug therapy. In terms of how likely are the various drugs that we may give, how likely are they to produce significant dependence over others? You can see a little graph here, and really the take-home here is that the oral route is less likely to produce significant dependence versus routes that have a much faster onset. So, like IV routes are extremely likely to cause dependence, IM routes as well, and it really also is drug specific. So drugs like codeine are less likely. Our Schedule II drugs like fentanyl, heroin are much higher, much more likely to cause. We're more likely to see significant dependence occur. We'll talk a little bit about withdrawal. Withdrawal, what we see here, withdrawal syndrome, it's kind of a accumulation of symptoms, and it's really caused or can be caused by abrupt cessation or withdrawal or a withholding of the offending drug. And so we can see that with abrupt cessation. For example, if we had an alcoholic who was admitted to a hospital and isn't able to drink, they can start to have withdrawal symptoms. If we have a rapid dose reduction, so simply the patient ran out of the medication, if we reverse the patient's drug with an antagonist, so let's take for example methadone, and we give them naloxone or an opioid antagonist, we're going to see potentially a development of withdrawal symptoms because we're quickly reversing the effects of that drug. So in terms of the perioperative concerns that we have with withdrawal, we want to make sure that we avoid the patient going through withdrawal during the perioperative period. That is not the time to start treating the patient for chemical dependence. They can be very unstable both from a physiologic and a psychologic standpoint. From a physical standpoint, they can be very hemodynamically unstable. Psychologically, they can be very unpredictable in terms of sedation that you're going to produce. So, in terms of managing withdrawal, we want to make sure that their patient essentially has their usual maintenance dose. We don't want to avoid withdrawal until well after the stress of the surgery has passed. In terms of preventing withdrawal from an inpatient standpoint, oftentimes that requires the use of or consultation with an addiction specialist, and it can require hospitalization. Oftentimes they're placed on a CWA protocol where they're given a benzodiazepine to help bring them down, and that can even require ICU monitoring and stabilization and intervention. Now, when we look at withdrawal syndromes that can arise, we do see some variation between the different CNS depressants versus non-CNS depressant drugs. And the withdrawal from CNS depressant drugs tends to be a little more serious and life-threatening. So examples of CNS depressant drugs would be like alcohol or chronic benzodiazepine use or abuse. Same thing with like barbiturate use and abuse. And once again, these are more life-threatening. They tend to be associated with seizures, delirium tremens, and then even death if not managed appropriately. Non-CNS depressants, when patients withdraw from those, it tends to be not as life-threatening. That doesn't mean that it's not comfortable for the patient. It just is not life-threatening from a hemodynamic standpoint. Some examples of some of the non-CNS depressant drugs would be like cocaine, marijuana, or opioids. When we look at delirium tremens, typically, once again, this is withdrawal syndromes that occur after patients are weaned off or come off of CNS depressant drugs rather abruptly. Alcohol tends to be the most common cause of DTs. Benzos and barbiturates can do the same thing. And really what we have here is an imbalance of the neurotransmitters within the central nervous system. And effectively what's going on is because of the chronic use and abuse of the CNS depressant drugs, the patient's central nervous system gets used to being depressed. And so we see downregulation of the GABA neurotransmitters, and then we're going to see upregulation of all the excitatory neurotransmitters, things like glutamate, norepinephrine, epinephrine, dopamine, serotonin. And really what's going on there is the system's trying to counterbalance the effects of that CNS depressant drug always being there. And then when we quickly remove that CNS depressant drug, the system is so far out of whack that it's not able to compensate. As far as the signs and symptoms of delirium tremens, we tend to see effects stemming from the imbalance between those neurotransmitters. We see, once again, a complete upset or imbalance between the excitatory and the inhibitory neurotransmitters. And so this manifests as autonomic instability. We can see a lot of electrical activity dysregulation within the central nervous system that will manifest as seizures or seizure-like activity. They can be dizzy, they can be confused, and all these are kind of suggestive of delirium tremens. As far as how DTs is treated, typically these patients are hospitalized where they're monitored closely and then their vital signs are stabilized. The main problem tends to be that autonomic dysregulation or instability. That's really where they get into trouble, along with the seizure-like activity. So one of the things that they do is they tend to taper these patients off by using benzodiazepines to kind of wean them off slowly. Next, let's move on and talk about drug abuse and sedation. In terms of how to manage patients that have a history of drug abuse and then whether or not they can receive sedation, some of the concerns we have, one of the most common concerns is that whether or not the patient's actually sober. We certainly want to determine that, and then if there's any question whether or not they're sober, we're going to delay treatment, especially if intoxication is suspected. Not only is this a medical legal issue, you've got if they're not sober, then clearly they're not able to sign for consent. Then you have also the whole host of honesty issues regarding their medical history, their NPO status, and then certainly what medications that they take. You have no idea. So not only are there medical legal issues, but also there's purely medical issues in the sense that the addition of these other medications being present, these other sedatives or alcohol or whatever, it's really going to make the sedation to be quite unpredictable. So, you take a look at the girl on the right-hand side here. She is in no shape to have any sort of elective treatment done. So looking at narcotics specifically and some of the conditions or some of the concerns that we have, a lot of the symptoms really tend to relate more to the mu receptor activity. So patients that are taking narcotics are going to have a potential for respiratory depression. You're going to see an increased risk of hypopnea or apnea. They may be constipated, and certainly they're going to have some analgesic properties on board, which can be useful. In terms of management, we're going to make sure that we avoid any additional opioids if they're acutely intoxicated on narcotics. And then from a long-term management standpoint, make sure that you've got adequate local anesthesia, and you can think about your opioid agonist or potentially your agonist antagonist potentially as well. Those patients on chronic chronic opioid therapy, we want to make sure that we avoid our mixed agonist-antagonist, because that antagonist activity can precipitate withdrawal symptoms, and the patient's going to be very uncomfortable. In terms of patients who are taking benzodiazepines, the symptoms that we tend to see are related to the GABA activity. So we're going to see our CNS depressant symptoms and effects, which makes sense. That's what these medications do. In terms of management, those that are patients that are chronically using benzodiazepines, these patients are most likely going to have increased anesthetic requirements, and then we certainly need to watch out for any sort of signs of withdrawal symptoms. In terms of patients that are acutely intoxicated, they're going to have a decrease in anesthetic requirements because you've already got those benzodiazepines on board. And then, we certainly are at a higher risk of unintended oversedation because of the mixing of the multiple CNS depressant drugs on board. Amphetamines are a class of drug that are more and more popularly being abused. These drugs are CNS stimulants, so the symptoms that we're going to tend to see are as a result of the stimulation of the central nervous system. So they may manifest as hypertension, tachycardia, alertness, they become jittery, etc. In terms of management for these patients, if they're symptomatic at all in terms of their hypertension or tachycardia, we're going to primarily treat them with adrenergic agonists. That'd be your alpha and beta blockers. In terms of chronic use, the chronic use of amphetamines may typically they have a decreased anesthetic requirements, and oftentimes they do respond relatively poorly to the indirect adrenergic agonists like ephedrine, and that is because of the depletion of the catecholamine stores that can occur when they're chronically taking amphetamines. So essentially, they've used up all their norepinephrine in their those vesicles in the presynaptic terminal, and there's nothing left when the ephedrine comes along and says, "Hey, we need more release of norepinephrine." From an acute intoxication standpoint, these patients are going to be probably have an increase in their anesthetic requirements. They're going to need additional drugs more than you would expect. That reflects the stimulation of the central nervous system. Cocaine is another drug that's relatively commonly abused. From a mechanism of action, remember cocaine has a couple different effects. Number one, it's a pretty potent local anesthetic, and it works just like the rest of the local anesthetics do in the sense that it blocks sodium channels. And then it also has another activity or mechanism of action where it's able to inhibit the monoamine reuptake transporters. And by essentially blocking the reuptake of these neurotransmitters, we see an increase in the concentration within the synapses of those neurotransmitters that are associated with the particular transporters. So things like norepinephrine, epinephrine, etc., are going to have an increased effect and an increased duration. The signs and symptoms that we tend to see with patients on cocaine really stem from the CNS stimulation or stimulant effects. They tend to be hypertensive, tachycardic, alert, and jittery. It's very similar to our amphetamines. In terms of managing patients who are on cocaine, they're primarily treated from an acute standpoint with adrenergic agonists and benzodiazepines. Patients that are chronically using cocaine, in terms of what I'm concerned with, we want to certainly be aware of the potential risk of the depletion of their catecholamine stores, once again very similar to our amphetamines, so they may not respond very well to our indirect acting adrenergic agonists like ephedrine. Also, these patients are going to be at risk for damaged myocardium, so they potentially could have had an MI, so be aware of that as well. From an acute intoxication standpoint, the current recommendations are really to postpone elective dental treatment at least 24 hours, or at least until they're no longer symptomatic. So you want to wait until they're not high anymore, essentially. Be aware that these patients will have increased anesthetic requirements and that you need to be very similar, once again, to our amphetamines. In terms of whether or not you can use local anesthesia is certainly fine with these patients. You may want to be aware of the additional effects and prolonged effects of the vasoconstrictors because of the multiple mechanisms of action associated with cocaine. Now let's talk about drug abuse and the healthcare provider. Chemical dependency is certainly an occupational hazard for a lot of the healthcare providers that are, around and in daily proximity to our sedative drugs. So we're talking about anesthesiologists, we're talking about sedationists, dentists that do sedation. And the main problem here is that these healthcare providers have really easy access to these highly potent drugs. Every day they're around or have daily access to, things like morphine, fentanyl, midazolam, and propofol. And these are all highly addictive drugs that really only take a time or two to really develop physical and psychological dependence. In terms of once a patient or once a healthcare provider becomes an addict, often they're the last person to really be able to recognize that they have a problem. They have a strong tendency to be able to deny that they have an issue. And so it's really our job as healthcare providers to make sure that we look out for each other. We want to take care of our friends and colleagues and coworkers and employees. And if we suspect that there is an issue, then it's really our duty to kind of investigate it further. In terms of narcotic abuse, some of the complications that can arise, they can be very tragic and serious. It can be anywhere from, they can be as severe as anoxic brain damage or even death. And that really stems from the risks associated with an overdose and the respiratory depression that can occur. That essentially, these people can overdose to the point where they're not able to ventilate adequately, and they can become hypoxic and die. Looking at workplace use for healthcare providers, believe it or not, it's actually relatively common and typically tends to be self-administered. These people, are very, very good at hiding the fact that they're using these medications at the workplace, and they're able to administer it themselves. This is a little graph that was produced based on the ASA, the American Society of Anesthesiologists data that was done looking at the incidence of abuse in anesthesiologists based on the training and the medications that we see. And the reported incidence is about 0.5% per year of anesthesia training or practice. So the longer someone practices, the more likely they are to potentially develop or be at risk of drug abuse and use and abuse. As far as the drugs of choice, the most common drugs of choice in terms of healthcare provider abuse would be your quick-acting opioid agonists, things like fentanyl, meperidine, sufentanil, and then another relatively new drug is propofol. Over on the right-hand side, you can see the graph, and really what we're looking at here is the difference in the speed at which the drug has to be used versus the risk of moving from abuse into addiction. And the thing to really take home is that a lot of your short-acting opioid agonists that have a very, very quick onset and are very, very potent are more prone, have a higher risk of causing a much quicker onset of addiction. So drugs like fentanyl and sufentanil, it may only take a time or two for the person to become addicted. A lot of the other drugs that maybe don't have that quick onset, things like morphine, meperidine, or alcohol, you have that period where they tend to abuse them before they become addicted. So it takes a lot longer duration to move into that addiction phase. Looking at, when we talk about recognizing impairment in a colleague, there are some complications and certainly some worry that can happen. Certainly if left unrecognized and untreated, obviously that can lead to loss of career. It can lead to health problems, as I mentioned. The worst case scenario would be anoxic brain injury or death. It can certainly lead to life problems, issues at home. And despite all these issues, I think one of the things that's really interesting is the research tends to show that even though use during the work is common, there really have not been very many cases of reported harm to patients. That's actually very, very rare. So I think that's more of an interesting fact than anything else. So a lot of times in the signs and symptoms of recognizing an issue with a colleague tend to be really kind of hard and really hard, really subtle. And that's because these addicts have a really strong drive to preserve not only their career, but to preserve their access to the drug. So they've got multiple things going on. So some of the things that would suggest that there may be a potential issue: if you see unusual behavior, mood swings, if they're taking frequent breaks or demonstrating, odd behavior, if they're volunteering for extra work, all these are signs and symptoms that they may have, you may be dealing with an impaired colleague. In terms of intervention, intervening with a colleague tends to be very an uncomfortable and stressful situation, and it tends to be actually a little bit easier if you're working in an institution with a department, because they have policies in place to really help with this. And that's one of the reasons in dentistry why it's so difficult is a lot of us are private practice people. We're going to have our own practice, and we really don't interact with our colleagues that much within that practice scenario. We kind of tend to be isolated, and so that makes it very, very hard. But if you become aware of this, and if you think there's evidence that exists that maybe you have a colleague that's impaired, and you want to intervene, it's really a good idea to involve an addiction specialist. These specialists will help facilitate the process and really, kind of guide everybody through it. And the goals here really are threefold. They want to inform the practitioner that, I think you've got an issue and we need to get you looked at. And then they really should arrange make arrangements prior to the intervention. And then you want to make arrangements to physically escort them to the facility. Healthcare providers that are addicted have a very high risk of relapse. And once again, this really depends on the drug of choice. And once again, these people really have to have a drive to want to change their behavior. If they don't want to change their behavior, they're really not going to be successful. In terms of the risk of relapse, if it's addiction to alcohol or benzodiazepines, there actually tends to be a fairly good prognosis in terms of if they want to change. They probably may be able to. When we add in a lot of our other narcotics, that's where the risk of relapse becomes very, very high, and it really is difficult to get these people to become clean and get off the drugs. So in terms of the plan of action for dealing with an impaired colleague in terms of helping them, it's really a multi-step process that involves a lot of medical and legal components. For the dental board, one of the first things that's done is the dental board is notified. They will typically suspend the dentist's license. This can be done voluntarily or involuntarily. So, the dental board has the ability to suspend someone's license, maybe who refuses to acknowledge they have a problem. They will also suspend their DEA license and CSR license. And then typically, what's recommended is that they enter an addictions facility or program, and then they need to complete the program. Additionally, the dental board has the ability to add on some other requirements in terms of what needs to be accomplished before you can get your license back. They can do anything from request or demand random drug screens. They can demand active participation support groups like AA or Narcotics Anonymous. They can require prolonged witnessed use of antagonists, things like Narcan or disulfiram. And they can even deny a sedation permit for life. It really all varies on the situation and the individual practitioner and kind of the history of that practitioner. Thank you for listening. If there are any questions, please notify me via email. Thank you.